So my name is Luciano Costa. I'm a multiple myeloma doctor at University of Alabama at Birmingham, and I'm here at the 65th ASH annual meeting in San Diego, where there's as always, a lot of new information about multiple myeloma. And I think one area of great interest is about sequencing of immunotherapy. I think we all saw over the last several years the development of several drugs or treatments that target this protein on the cancer cell called BCMA. That's the target that's used, for example, for teclistamab, that is currently approved, Carvykti, a CAR T cell therapy, Abecma, a CAR T cell therapy, and in the recent past, belantamab, an antibody drug conjugate. And in general, in oncology, and particularly myeloma, there is this notion that once I target a certain protein with some sort of immunotherapy, I may not have the opportunity to go after that protein again because the cell develops some mechanism where that protein is no longer expressed, the protein gets modified. There are a series of different mechanisms. So that always creates the interest of what I'm going to do next. And I think the news that are coming out of this are actually very good. For the most part, BCMA is not a target you can only use once. There's a lot of data now that if you have, for example, a CAR T cell therapy directed at the BCMA, that patient is still and you have a response and enjoy months-long response, that patient is very likely to respond to either another CAR T cell against BCMA or a bispecific antibody like elranatamab or teclistamab directed at the BCMA. Actually, there's relatively small difference between the chance of response of those patients who already receive a BCMA CAR T cell and those who never receive any BCMA-directed therapy. The other part of the good news is that there are other targets that are being further and further explored. One that has been talked a lot about is GPRC5D, which is just an abbreviation with really no great meaning. That's a protein that sits on the surface of the myeloma cell that doesn't have any known function, but makes it very targetable to immunotherapy. And that has been accomplished through talquetamab, that is a FDA-approved T-cell engager that has chances of responses as high as 75%. And interesting enough, if you take patients who never receive a BCMA-directed therapy or patients who already receive a BCMA-directed therapy, the chance of responding to talquetamab are very close. They are all north of 70%, really proving the point that those targets operate independently, and after you are done abusing one and to your benefit, you still have the opportunity to go after the other and regain disease control. Another piece of information that was shared at this meeting was, for example, an update on a very interesting program with a CAR T cell directed GPRC5D. So now it's possible, for example, for patients to receive a CAR T cell against BCMA, enjoy many months, sometimes years of remission, and then receive, perhaps in the near future, a CAR T cell directed at GPRC5D and have another long remission, or the other way around. The sequence on how you go after those targets, that doesn't seem to matter. The other part that is way into the future, but is starting to look a lot brighter, is the possibility of going after those two targets at the same time. So there are now, in very early development, some CAR T cells that target both GPRC5D and BCMA. And we saw at this meeting for the first time the preclinical work of a bispecific antibody that goes after BCMA and GPRC5D that is now entering the clinic. So think about combining, for example, teclistamab and talquetamab on one single product. So the future, of course, continues to look very, very promising and hopefully very bright.